Good morning, everyone. Thank you for joining us today for the final webinar in the Revenue Cycle Improvement Series with BKD. I'm Shannon Norman with the National Rural Health Resource Center. Today's webinar will be recorded and the playback will be made available on our website along with the slides from today's presentation. Once it's uploaded, we will send a notification to all hospitals that the recordings and presentations from all 5 webinars are live on our website. The topic for the webinar today is Revenue Integrity, Denials Management, and Charge Capture Best Practices. Our presenter today is Jen Goins, Managing Consultant with BKD. Before turning it over to Jen, we have one poll question. Cineva, will you please pull up the poll? All right, thanks everyone for participating in those polls. If anyone has questions during the webinar, please feel free to type them into the chat box on the left-hand side of the screen. Otherwise, there will be an opportunity to ask your questions at the end. All phone lines are muted, so if you do want to ask a question at the end, just press *2 to unmute your line. Jen, please go ahead whenever you're ready to get started.
Great. Thank you so much, Shannon. I'm glad everyone could attend this morning, and I did realize when I was looking over these slides that I didn't put my contact information in here. So if there are any questions afterwards, feel free to reach out, jgoins, G-O-I-N-S, at bkd.com. So let's go through the agenda real quick. I will say this is the first time I've done this presentation, and yesterday I did a presentation on denials management and prevention, and it was an hour long. So I know I can talk a lot about this topic, so I will make sure we get everything covered within our allotted time. So we're going to talk today about revenue integrity and what's kind of included in that, looking at how the clinical revenue cycle needs to function, talk about charge capture, reconciliation, other revenue integrity kind of charge-focused activities, and then we're going to touch on denials management and denials prevention. So a lot to talk about. So when we first talk about the clinical revenue cycle, this is a newer kind of concept. I think it's just a newer way to look at how to organize your business and how your teams, the traditional clinical sides and the business office or financial side should really be working together. So traditionally, you've had your clinical side that's been focused on the documentation. You needed it to be clear, accurate, compliant, and then it supports the charges that are billed. And then your business office was really focused on the charging side, making sure that they were timely, appropriate, you've got everything reconciled, and that those charges are supported by documentation. So really kind of two very siloed functions. And now what you need to be able to do is look at the clinical revenue cycle as kind of a complete interdisciplinary approach to really providing care and going all the way through till payment and receiving that revenue. So I've put in here what the HFMA's definition of the clinical revenue cycle is, and it's looking at all administrative and clinical functions that contribute to capture, management, and collection of patient service revenue. So this is really trying to break down those walls and those silos and saying, you know, clinical side, you can't just function and provide services and not really care about the money side of things. And then on the business office side, we can't just say, well, we'll just fix it. Just let the docs do whatever they're going to do and we'll just fix it. That's really not a good way to approach clinical care and your financial functions. You really all need to be working together as a team so that clinical services are are provided, captured, and it all ties back to finances and having a good financial performance. So within the clinical revenue cycle, what we have here kind of on the left are some focus areas that are pretty common within clinical rev cycle functions, and then what kind of is that operating model of how a clinical revenue cycle should really try to function. And all of this is really setting the groundwork and the framework for really having strong revenue integrity services that really incorporate the compliance aspect, the timely and appropriate charge capture aspects, and then through like billing and payment side. So when we look at those focus areas, this is where you could see teamwork and facilitating that clinical and revenue cycle side. And really what I also want to make sure is clear here is that what is very helpful in creating this kind of environment and this kind of really it's a culture shift is that everybody understands what their portion of their work is and how it impacts everyone else. I think one of the things that can be really detrimental to your facility is to have someone who kind of has blinders on and says, this is what I do. I do every day, I do X, Y, and Z. I do X, Y, and Z. And if you think about it, if it's like a registrar, okay, I put in an insurance, I check the patient in, and I collect their copay. But if they don't understand the importance of getting the correct insurance and that they get the correct payer and plan, that they're just like, oh, your card looks like a United Healthcare, I'll just go ahead and pick one. Well, there's many varieties to that. So I think really what's important here is that making sure that everyone within the hospital on the clinical and revenue cycle, this whole incorporated model, that you really understand what your job is and how important it is to the whole kind of life cycle of the hospital. So, so that to me is really kind of what this whole concept of building this clinical revenue cycle that will really help with the revenue integrity processes. So when we look at some of those focus areas, we're talking inpatient, outpatient clinical documentation. Obviously, the documentation is always the start of supporting any kind of financial charges, payments. That's kind of where everything starts there. Obviously, part of that would be patient acuity, so getting statusing appropriate. If you have a CDI team, which is clinical documentation improvement, having that component along with coding. You've got denials. You've got, as I mentioned before, with patient acuity, care management or utilization review. You have charge capture processes, and then also your charge master, your CDM in and of itself. And then when you look at kind of the operating model of this is where you want to make sure that clinicians are engaged and understand that they really have a role of identifying and helping preserve that revenue. So if you have doctors who are, maybe it's a new service line that comes to your facility. Maybe you're going to have a cardiologist who's going to, be at your facility once a week or twice a month. Or you have another orthopedist that's coming in, is really having the conversation with them to understand what is it you're doing. Help identify for me, that we have all the right charges created for you, that we understand what your documentation is going to look like, that, you educate us on your services that you're going to provide, and we're going to educate you on how we need documentation and charge capture to occur here at our facility. In order to kind of pull this all off and work to make this a cultural shift, you also need some sort of governance and oversight structure. It's really helpful to do that as part of a revenue integrity kind of model, and then this fits in so perfectly with that model. So, and this isn't just, it's financial at the top or clinical at the top. To me, it's a joint responsibility. There should be both representation from both sides so that it is truly identifying that this is, two groups that are working together for this. And again, this is a culture shift. This is not, you're not going to be able to go in and say to everyone, hey, we're going to have a clinical revenue cycle now. You're going to need months of preparation and work and conversations and modeling the behavior that you want to really work towards a culture shift. And then lastly, it's really understanding on the clinical side and the business office side, what technology do you have available to you? What are those workflows? And how do those need to be integrated? I participated years ago when I worked on the hospital side in a large-scale EMR conversion, and it was daunting, but I will tell you there was so much involvement from both the clinical and the business office side in, clinical folks, you tell me, let's hear your workflows that you need, and then we on the business side can have the conversation with you of where we need to stick, pieces and components to make sure we have appropriate documentation. Are we able to affiliate or associate charge capture at this point? Let's make sure, our order set is written in such a way so there's not ambiguity where we're providing services that aren't covered. There's all sorts of stuff here. I will tell you that this is definitely one of the areas where you can say, what documentation do we have and how can we generate charges or anything from that? And that's one where I think both groups together need to really have those conversations and understand. I know I had a lot of nurses that were like, well, wait a minute, I thought we were just going to be able to type our notes in like a text box and then you guys could figure out how to charge from that. So like my words automatically charged. And it was like, oh, no, that's not an option here. And it was kind of, recentering and refocusing what the capabilities were and what we needed from them to be able to support some of those charges. So again, this may sound a little daunting. This is not something that you're going to be able to flip a switch and do overnight. This is a process, but I think it's a good process to move towards. And then kind of looking here, who are some of the different teams involved, or how are you kind of, or the activities that you're doing between the business office and the clinical side. So obviously you have physician advisors, your case managers. Those can be a lot of people that already are kind of one foot in each world. Or each silo, if you want to say, and that can really help bridge the gap here to have get more involvement and really get the focus for this kind of rev cycle and cultural change, so that you have a stronger revenue integrity process. So again, I can't say enough. You really need a really good, strong physician advisor who understands the importance of the financial side of the business, and that really can rally around the other clinical staff so that they can understand the importance too of this. And then can have other functions such as, which we'll talk about here shortly, about charge capture and reconciliation. And then really we'll go in some more too about having an interdisciplinary oversight group and how reporting can be extremely beneficial to that group. So an important part of revenue integrity is charge capture and charge reconciliation. And when we think about charge capture, there's multiple things that kind of come to mind with making sure that you are getting your charges captured. And the first thing is timely. Those charges need to be posted on that patient's account as close to when the service is rendered as possible. I know I say that, and people are always like, well, what about emergency situations, and what about, and I understand that, but really the goal is you really want those charges posted as soon as possible after that service is provided, especially if those charges have to be done manually. People forget, they get busy, and then they forget to come back to it, or they think they've already done it. So timeliness is always an important component of this. And then making sure that everybody, not just the business side, but the clinical side, how is that charge posted? Most facilities have some component of an EMR now. They may be fully on an EMR, partially on an EMR. Is it still manual charge entry? Does it somehow, if you have certain boxes checked, it can generate a charge from that? Is it based on an order being placed? I sure hope not. Is it driven off of a result coming back, like from a lab or radiology service? How are your pharmacy charges dropped? Are they dropped at the time the patient is administered the medication, or at the time that it's dispensed from the pharmacy and it leaves the pharmacy? So it's very important that all of the ways that charges can be posted, that everybody really understands that, whether it's manual or not, and kind of what the process is for getting those charges posted. And then also wanting to make sure that you have appropriate charges for your specific departments or specific locations. There's nothing that will lose you revenue quicker than if you're providing services in an area that you don't have charges set up for. So this is where it is good, again, as I've mentioned before, about your clinical team, understanding and identifying and kind of being the driver for the revenue. They need to remember, hey, I'm starting something new. It's a new service, or this is going to be a new procedure we're going to be able to do, or we've switched vendors on supplies, and we now have different supplies that we're going to be using for a certain procedure or at a certain location. Those are all times and instances where you need to be having conversations and making sure that you do have those charges available to those areas that can provide those services. And then there's also always your charge code maintenance. Typically this falls to your charge master team, where there's code changes, there's annual code changes, there's quarterly code changes. Someone needs to be on top of those. That's another area where doing charge master reviews, it's always sometimes surprising to see how many deleted CPT codes are still alive and breathing within a charge master. Honestly, we found some that go back, 10 years or more that haven't been active in that long. So somebody needs to have a regular process for this, and looking at your CDM, making sure those charges that are no longer active, those CPT codes or HCPCS codes that are deleted, get them out of your charge master. You don't want those in there. You don't want someone to continue to charge for something that's on a code that isn't active anymore. And then the last two are really important components, and I know these are probably the least favorite of most people to do, and they're sometimes the hardest to keep up on, just because it's always like policies and procedures and education and training. But they're two very important components. Your policies and procedures, making sure you have those in place, they're readily available for folks to access, that they know when something has changed in your policy or procedure, and it's somewhere that they can go back to, that if they have a question or forget or need a refresher, they can go back and reference your policies and procedures. And then really education and training, new hires, transfers, always, always important. But really the education component is, I think it's an ongoing thing. You can't just meet with someone when they're hired and say, hey, here's your charges, this is how you post your charges, and be done. There should be some sort of ongoing education conversations. New charges or new CPTs and HCPCS come out, hey, do you guys need any of these? Are you doing these? Or, hey, your second highest volume charge, that CPT is now being deleted, and it's being replaced with these three. Do you need all three? How is this going to work? That's really that ongoing education and training that should, be happening kind of year-round. Don't just let that sit for once a year. But again, that's always a hard one to get in because sometimes it can be, when do we have time? Make time for it. Make it be an activity that is something that is ongoing. So let's talk about then your charge capture and charge reconciliation. So charge reconciliation. So this is really looking at the charges that have been posted and reconciling those back to, well, what should have been posted. And so a good place to start is to use your revenue and usage reports that you can get. You should be able to get those for your cost center or your department or departments. You should be able to run those for a specified time frame, and those should be readily available so that you or someone on your staff can look over those on a routine basis to make sure that you're really capturing your charges. I put here the reconciliation process. This is actually Google's definition of reconciliation. So it's really looking at, and it, I put on here a word that I'm like, harmonization, I think is how you pronounce it. I was kind of laughing this morning. I'm like, wow, I put a word on here I'm not even sure I know how to pronounce. But basically being in harmony, that they're consistent, that if you had 10 people in your inpatient unit last night, you better see the next morning 10 room and bed charges, that what you expect to have been charged has actually been charged. So that's kind of a very loose kind of way of thinking about your reconciliation processes. And around this, your reconciliation really is where policies, procedures, and having expectations. When we talk about the charge reconciliation process, you have to think, what are the expectations for a small clinic area versus your pharmacy, or an inpatient unit versus your lab? So for me personally, I would say, well, if your clinic area sees, let's say, 25 patients a day, my expectation is you should be able to reconcile 100% of those charges. It's 25 patients. You should be able to look at your previous day's schedule, validate all 25 showed up. You should have 25 E&M charges for those patients being there, and then you should be able to tell, were any of those had a scheduled procedure, lesion removal, something like that. Can I see that we've got those charged? It should take 5 minutes, 10 minutes at most every day. That would be an expectation for a smaller clinic area. Now for your pharmacy, I would not have the expectation that you should be able to reconcile 100% of your charges. Same thing with the lab. The volume is just too great. But that doesn't mean that they don't have to participate in reconciliation processes. It would just be that their reconciliation processes are a bit different and would have different data elements to look at. I would think an inpatient unit could be very similar to a clinic area. You should be able to see what your census was at midnight, how many patients did you have were inpatient, how many were in observation. You should be able to validate you've got the inpatient room and bed charges that are the appropriate level. and your observation charges. And then you should also be able to tell what other, do I have bedside procedures that were charged? Do I have supplies? And those kind of things. And you should be able to quickly have reports at your fingertips to look at and validate that everything is posted as expected. So let's talk a little bit more about some of the charge reconciliation examples that that we would have. So as we're just talking about inpatient nursing unit, looking at the daily census, looking at your room and board charges. Do you have bedside procedures that you're charging for? Are you seeing those getting posted? Are you charging for supplies? Are you seeing those on patient accounts? And for every single one of these, there needs to be at some sort of interval, some sort of sample auditing that is being done. So may not need to be every day, maybe once a week, maybe every other week, where a couple accounts are randomly selected and you're validating, yes, the patient was a med-surg room, they've got a med-surg room and board. I can see in the notes that the patient received a Foley catheter and some wound care. I can see my supply charges, and I can see that we have the bedside procedures charged as well. This can help identify if you have charge capture issues, if maybe you have an education and training issue, maybe you have a new nurse on staff that is forgetting to charge for his or her supplies they're using. Maybe you have a veteran nurse who didn't realize that you now do have some new charges for bedside procedures. So this is where, again, the education and training can come in to play, and you can do that easily by sampling some of these audits. And this doesn't go just for inpatient nursing. Doing some sort of sample auditing on a regular basis is necessary, I think, for every single department to do. Pharmacy and lab, and I'm going to jump down one, radiology. So all three of those have an asterisk beside them. And why I have that there is those are kind of the three areas or departments that tend to have more interfaces, where you may have an EMR for your clinical documentation, but your radiology is on a different system. And the documentation is contained there, and that's where, you know, all the results are, and then they send a message to the patient accounting system to post their charges, or they send the results into the EMR. So this doesn't mean that this is how this has to go. I just want to call this out for those of you that may have those systems as a separate system, and there's interfaces between the two. If you have those, imperative that you are, someone is monitoring what is called your interface balancing reports. So this is where your pharmacy system, let's say at night, it batches up your charges and sends them all over after midnight for processing. That there needs to be a report that says, from the pharmacy system, I am sending you 5,000 charges. And then there needs to be a report from your patient accounting system that says, I received 5,000 charges from the pharmacy system. That right in and of itself is going to be, you can see they balance. What the pharmacy system sent and what we think it sent is exactly what was received by the patient accounting system. Because if you're sending 5,000 from pharmacy and only 3,000 are posting in your patient accounting system, you have an issue that needs to be researched and fixed as soon as possible. That means you're missing 2,000 charges are getting lost between your pharmacy system and your patient accounting system. So if you have any of those interfaces, I highly, highly recommend you talk to your IT team, make sure you have some sort of balancing report that's run every day and it goes to somebody's inbox or multiple people where they're monitoring it to make sure that you're not having issues, charge capture and reconciliation issues where you're just, charges are going to a black hole. And then for some of these, like larger systems, so like pharmacy and lab, this is where a reconciliation process could be just to be looking at your average daily charge volume and your dollars. If it's pharmacy, if you have a Pyxis machine, you need to be looking at your cabinet overrides. There should be some sort of reporting that comes out of Pyxis if you have one to use. or any kind of supply stocking system where in an emergency situation they can do an override and like the doors pop open and they can grab medications or supplies that they need. This is very, very important, not only from a charge leakage issue, but when we talk pharmacy drug diversion, that you want to make sure that nobody is doing overrides to get their hands on medications that they're not giving to a patient. And again, this would definitely sample auditing here. We'll keep talking about radiology for a second too. Again, looking at what are your expectations and kind of what are your trends on that average daily charge volume? What are your dollars? Can you compare your radiology schedule to your charges where you know you had 4 CT scan patients today, 5 MRI scan patients, having that summarized from the schedule to compare to what charges have posted. Very, very beneficial. If we jump back to your operating room, again, this is another one where it's excellent to look at your schedule. What were we scheduled to perform today, and do we have OR charges on those patients? Did we use any type of implant? Did we use mesh for hernia surgery? Did we use orthopedic implants? And if we did we get those charged? Did we capture all of those? And the big one I have here is trunk stock. If you're not familiar with it, it's basically when you have a rep who comes in who is providing some sort of implant or device to the surgeon day of surgery. So it's coming from their car trunk, and it's maybe something that it's too expensive. You're not going to have it sitting on your shelf. You're going to get it the day of to do the procedure. This process can be extremely challenging to manage, and this is something that you want to make sure your OR manager is very involved with, or there's a couple people in the OR who know that you just don't have stuff coming in and it's getting to accounts payable where they have to pay for this device and it's never getting charged on someone's account. So if you have docs who are doing any kinds of procedures like this, might be a good time to call up your OR manager and kind of ask them what the flow is, what the process is. And there's always a paper trail because those vendors make sure that they leave those invoices. So just make sure there's a good flow for that and a good way to reconcile those charges. And then again, I think we've kind of talked about clinic and looking at your schedule to your clinic charges. Another good thing that you should monitor with clinic related is monitoring your evaluation and management distribution. So this doesn't necessarily have to be for the professional side. If you're doing professional charging, highly recommend doing it for them as well. But your technical charges, so you should be looking at what that E&M distribution is for that area and monitoring it. This would not be, I would not look at this on a day-to-day basis. I would probably look at this month to month, and I would trend it over the past, 3 months and look at it, at a quarter of a time, kind of where your volumes are going and then which level, and just to make sure that that is kind of tying to that patient acuity and your clinic level criteria that you would have for your facility. So let's go through here where we've added like a charge reconciliation example here. So if this is 2 South Nursing Station, and this would be their daily census as of midnight, you can see all of my friends are here. That is a joke. For this date, here's the patient's names. You can see what rooms they are in, and you can see what status they are. So I would say from here, what charges should we be looking for? And we'll flip to the next slide. And this is where I would say, so there's looking at your census. This would be kind of looking at your revenue and usage report. So I'd be looking for, do I have a room and bed charge? Do I have any bedside procedures and supplies? So you can see for our patient Ross Geller here, he does have a room and bed posted, a bedside procedure for wound care, and then some supplies here. Chandler just has a room and bed charge. Monica has observation, and she's got some infusion charges. And then Rachel has a room charge and a vaccine, and then Phoebe's got her room charge. And then you can see here what should happen on your room or your revenue and usage report is, oops, a nurse charged wound care and then credited it off because really that wound care was done for Ross, not for Phoebe. So kind of a way to look at this report and kind of do that reconciliation based on the previous night's schedule, or census, I'm sorry. So some of the other areas that your revenue integrity can also look at, which is important, would be obviously your CDM oversight and your maintenance. What is the process for that? And really part of that is pricing. So part of having good, strong revenue integrity processes is making sure you have a pricing strategy, that there is a pricing structure in place, that you have kind of a policy around what that is. That can be, and this helps to have your markup formulas for supplies, for drugs, that you're marking up off of cost, and then how do you set your pricing for other things like your procedures or your ORs or your radiology. It could be market-based, it could be strategic. There's all sorts of ways to do this, but just making sure that there is some sort of oversight and that it makes sense and that it's defendable, especially now with the pricing transparency requirements that are going to be effective 2021. Very important to have this included as part of that revenue integrity process. As I mentioned before, education and training, new hires, transfers, promotions. You may have a nurse that has been, an excellent nurse for years on your floor and now is being promoted to the manager. He or she may have no idea that there's charge reconciliation processes that the previous manager was doing. Have a sit down, get some coffee, go through the reports, talk how they should use them, educate them, listen to them on some of their feedback. Imperative to do. And then there should always be some sort of quarterly or biannually training that is done for all staff that have anything to do with charge capture, charge generation. Always auditing doesn't mean 100%, but there should be ongoing auditing that is happening for all departments, all physicians, that it is checking to make sure that you have documentation to support charges, that there's no charge leakage, which means, we're doing all these services and we're not charging for them or we don't have charges for them. And then really having, again, as I've mentioned, it's an interdisciplinary team for the oversight and accountability. So here is, in talking about creating that team and that structure, on the left would be who or people from what area. So if you already have a revenue integrity department, obviously they're imperative to be a part of this. If you don't have a revenue integrity department, then this is where you can have this revenue integrity committee to kind of include all of these individuals regarding your charge capture, your charge reconciliation, your denials, all of those components. So you definitely want people from CDM, from billing. Managed care contracting is very important. I know some of you are smaller facilities and some of you wear multiple hats. Then you're the lucky person that can be in attendance, and you need to make sure you're wearing multiple hats while you're having these conversations and talking about these processes. CDI, if you have it, definitely your HIM coding, and whoever your physician advisor or advisors, if you need more than one, are there. And then these would be, on the right then, would be areas that you would be covering. Making sure you have conversations. Do we have right policies and procedures in place regarding our expectations around charge reconciliation, our charge capture process? Do we have policies and procedures regarding the documentation requirements that physicians have to meet for HIM and for, appropriate documentation? Is that where you need to put a policy in about querying physicians and what the expectation is for their response time frame and response rate? Again, pricing strategy and updates. we've kind of talked about that. Having monthly and quarterly revenue monitoring. What's your department budget? Radiology, where are you coming in at on your department budget right now? Are you on target? Are you under? Are you over? That is key to seeing and having a good understanding of what's going on in your facility. If radiology revenue is down, why? Is it because your volumes are down? Did a competitor just open in your area and now a lot of patients are going there? Or is your revenue way up and you're seeing way more because maybe another facility closed and now you're getting patients from other locations? There's all sorts of things that you can suss out, I think, from really looking at what your budgets are for your departments and then comparing it to where you are with your actual revenue. And then again, this committee can work on what are your charge audit and oversights for your documentation. Findings should be reported here. Unfortunately, do we have a doctor that's got a problem? And that's where these conversations need to be had, because again, it goes back to, do they need more education and training? Is there something that they're missing? Or do they just need to have a conversation that, you know, you need to get on the bus with the rest of us. This is how we're doing this, and you need to up your game and kind of get on the bus with us. And then obviously any billing issues related to charges. And this can kind of go back to billing, coding, managed care contracting. Is there something in your contract that this certain payer wants a HCPCS instead of the CPT code? And nobody knows about it. Do you need to change that? Is there something that's constantly getting denied for a certain payer, and why? Is that a contract agreement? Is that in one of their provider policies, their provider manuals? You can really have good conversations there, and really, again, having all parties involved, you can kind of prioritize your issues and come up with good solutions that work for everybody involved. So let's talk about denials management prevention. I've got about 18 minutes, so I will make sure I get my hour-long talk squeezed down into 18 minutes. So when we talk about denials, there's denials in general. We typically think of it as denials management and denials prevention. And denials management is really the process that I think most people are working. It is trying to control the chaos. It's trying to herd the cats. It's trying to get your arms around what is coming in and how are we prioritizing and how are we going to appeal these or follow up or rebill or whatever it is that needs to be done. That's kind of the management of denials. But the denials prevention, this is another like cultural shift. And you know what? If you're going towards revenue integrity, then just jump right on the denials prevention bus as well. And this is really trying to go upstream before services are delivered and make sure your processes are in place to mitigate the denial in the first place. And this can be focusing on either technical or clinical denials. So really here, the goal of denials prevention, I found this quote and I really liked it, was that is to turn your denials, like turning your denials data into information and the information into insight. So it's really trying to say, what is my denials data telling me? What is this information? And how can I take this to find some insightful information that is, this process is broken and I need to fix this process. It sounds overly daunting. It can be, but I will tell you, if you take this small chunks at a time, it is completely doable. So you need denials data, and you need that to be able to monitor what's going on, to track over time, and then report out on that information. And then you can see where your changes have occurred and how that's impacting those denials. And really, this is really looking at process improvement and opportunities. So it's those kind of things that are people, process, technology, where you can put some effort, get to the root cause of the problem, put in a process, and then monitor how that works going forward to see the outcome of it, which hopefully, and the goal should be, decrease denials. So one of the ways to do this, and this is really getting into the weeds. So this is making sure that you have some staff who are able to really do some data analytics, to really dig in to the information, to really figure out what in the world's going on. So the first place to start is you need to take those ANSI codes or those claimant response or the remark codes, and that's kind of your starting point. All payers have to use those codes, but all payers don't have to use them the same way. So therein lies part of our problem. So this kind of suggested route to getting down to the root cause of denials is you can kind of bucketize them based on those codes and those remarks and how they come back. An initial review should be done. So let's say we're working on prior authorization denials in radiology, and it's kind of all across the board with all of your payers. An initial review should be done, and you should be looking at, what was denied. Okay, there's no prior authorization. You look in the chart, or you look on the claim, there's no prior authorization number on the claim, but you start looking through the information within your EMR, and you find a prior authorization. Okay, so now, and you start looking, and let's say you have 100 of those denials, and 95 of them are that way. Oh, well, something's going on here. My prior authorization number is not getting on my claim. So there's kind of a bucket and a category and a root cause here of that issue. Maybe it's not that obvious. Maybe of those 100 denials, you have 10 that are that way, and you may have 30 where truly nobody called and got authorization because they were put on the schedule that day that they had the service, and they couldn't even route through the prior authorization process. So this is where you can start categorizing those kind of issues to say what on an initial review, what's it actually look like? And this is not where you have to go really, really, really deep on this first pass. But then someone should be working those denial to get it hopefully resolved. And after you've done that additional review, then there should be a final category assignment. So it could be it's originally assigned as no authorization for the MRI, and that's a hospital responsibility. So this is a hospital problem. But then the final category could be, oh no, we had it. It's a technical issue. The authorization's not passing from our patient accounting system onto the claim. So we need to get IT involved to have them help us so that it will get on the claim and will stop these denials. So some of the examples I have listed here, it could be insurance coverage issues, it could be coordination of benefits, and then the last one I always like to point out is around prior authorization, because that seems to be an area that everybody struggles with. If your facility is set up where the hospital is responsible for prior authorizing certain services, and the physician office is required or responsible for prior authorizing other services. So the physician office may do surgeries, but the hospital may do radiology. Then make sure that you have 2 separate buckets to track those, because this will help getting and driving down to really where is this problem, because then you're not incorrectly going after a group to say to the physicians, you guys are never prior authorizing your surgeries, or you guys are what's causing our prior authorization problems. And if you split it and put it in these buckets, what you may find is there were 2 surgeries that weren't prior authorized right, but 350 radiologies that weren't prior authorized right in the past 6 months. So This helps. It helps you focus where the issues might be and where you may need the processes to be improved, or you need to revamp the whole flow of how everything's going. Then on the right would be if you get to the point that the denial is going to have to be written off. So you have reviewed it, your appeals have been exhausted, or it is a claim that you cannot appeal. It's like a fatal denial. Then at this point, this is your final determination and of what this denial is, and then this is like the final category on how this gets written off. So this could be for things like it could, and what we've seen before, I've seen it a lot, is denials come in as prior authorization, and you end up, after doing your full review, find out, oh, no, we had a prior authorization. It's because we didn't meet medical necessity for the drug. So really the write-off is a medical necessity reason, not a prior authorization reason. So there's a difference that can happen there. Everything doesn't always line up the same. What your initial denial, kind of final denial reason, and then your potential write-off, they don't all have to go in a line. It could be it could bounce around because, again, as I said, those ANSI codes that come back, insurances, they don't all use them the same way. And then obviously, as I've harped on, the importance of having your denials bucketed if it's a hospital prior authorization or a physician prior authorization, you also want your write-offs to reflect that as well. Because then that helps, you can see very clearly when you have a prior authorization issue, how many are being denied, that's the hospital responsibility and written off, and how many are being denied and written off that are physician responsibility. It's very important if you have these processes, I feel, to definitely delineate your denials tracking and your write-off tracking in this manner. And then this is nobody's data. This is all made up for this slide. This is just a way to be able to take your denials data and kind of the information we're talking about, and then turning that data into information and insight. So these are various ways that once you have all of these data points, that you can then start slicing and dicing the data. You may need the pie chart on the left. You may need to look at what is your percent of denials by payer. Maybe it needs to go higher and it needs to be by financial class. And then within financial class, you can drill down to payer. The chart at the very top, this is, you definitely want to look at your denials by department, and you need to look at them by volume and dollar, because if you solely look at dollar, you could have one denial that's a high dollar drug versus you could have 1,000 denials for lower cost items. So, and then to do some trending around this. So that kind of third box right there where it's comparing the denied dollars to last month, and you can see, like the bottom one, cardiology, it's 100% increase, and people might go, oh my gosh, what has happened? Well, if you look to the right, the previous month, you didn't have any, and now you have one. So yes, it is going to be a complete increase here. And it's also a good way to say, well, rehab has the lowest amount of dollars denied, but the second highest volume. So there's all different ways that you can look at this and approach this once you have this data, and different ways that you can display this data, especially because sometimes different groups need to look at it differently. And then the last one is just saying, and I hope this is none of your facilities, where the number of claims denied in the purple bar is also matching the blue line, which is how much is getting written off. So you definitely don't want that. But just different ways that you can take this data, and just giving you some ideas of different ways that it can be displayed. And then really in moving to denials prevention, one of the things is creating like a steering committee. And I know now I've thrown at you having two different committees, revenue integrity and denials management steering committee. These can be a lot. This is a lot of the same people. And this is where you would have, your creation would have a steering committee and then your subcommittees, because your steering committee is really the leadership that's going to drive the change and why you need the change, whereas the subcommittee, those are the workers. Those are the people that are going to put in the change, that are going to do the heavy, heavy lifting, and that are going to get in there and figure out where the process breakdowns are, and they're going to write new policies and procedures and train and educate staff, and then they're going to be collecting and monitoring that data to see the improvements that are happening. And this doesn't necessarily have to be monthly meetings, weekly meetings. Steering committee may need to meet just quarterly because, as we all know, it takes a while to see the needle move on these denials because it may take 6 to 8 weeks of digging in the weeds to figure out what the root cause is and what the breakdown is. It may take another 4 weeks to get your process in place and what needs to be changed. And then it may take 2 weeks to roll it out in education and training. Well, there's almost, there's almost a quarter there. Then you may need, then after you start billing, you've got, 30 days or more for some of the payers to respond. So there really is this lag time that goes with this kind of process. So meeting frequency, obviously you can set this up, but this is not something you want, if you're planning on doing, to put on the back burner. You want to have accountability, and you want to have frequency with this so that you can tackle the things that you need. These are kind of some of the folks that I would identify as being necessary to be part of that, the steering committee and the subcommittees. I think most of them are pretty obvious. The ones I want to talk about are the support staff on the right. IT, you definitely want them involved. In my example, if you find the process breakdown is that prior authorization number is not getting from your accounting system to your claim, you need IT there to help figure out why it's not and to do the fix. Managed care, you want them involved because you don't want them agreeing to contracts that are impossible to be implemented. And this, I've heard this seriously, where managed care contracting went to a meeting and was talking about, they were like that day getting ready to sign this contract, and our case management was like, we can't implement, there's no way that we could ever operationally meet those requirements in that contract. So making sure they're involved and hearing all of these kind of things, they can also be your voice back to those payers or to your hospital association for help if you're being, your denials, are out of control for certain payers. And then always good to have quality involved to make sure, initiatives that are being done are not going to negatively impact any kind of quality initiatives. The things you should focus on, those denials that are preventable, process-oriented, high volume, or high dollar. Doesn't necessarily have to meet all 4 of those, but definitely preventable is like the key here. These are the things to try to tackle first. And then it's really, what's the process? What do we need to change to fix this? And then monitoring it. And really, I think doing this and sharing these results with your staff really enforces that sense of accountability and inclusion, that you're all part of this team. We're all part of, improving revenue integrity and our financial performance. And I think it's just really helps to get the buy-in. So in summary, with about 3 minutes left in case there's any questions, the Rev Cycle Management Guide that is out on the website, definitely refer to that. There is a lot of information in there from my presentation today that is in that Rev Cycle Management Guide. So use it, read it. You can take the slides, reference them, reference back to that management guide. And just really remembering that revenue integrity is really a team effort. You're trying to get everybody to work together, to get documentation and charges that are appropriate so that you're getting appropriate payment. And that really understanding that charge capture is really a central function for all kind of revenue integrity aspects. And then lastly, on your denials management and prevention, use the data you have and really try to make that data work for you to identify issues so you can fix processes to really try to reduce that denial burden that everybody is feeling. So I will open it up to see if we have any questions, comments, thoughts. Shannon, I'll turn it back to you to see. I don't see any questions, but I don't know if any others came in on a different way.
Thanks, Jen. While we're waiting for questions, I'm just going to pull up the first set of post-polling questions, if people wouldn't mind taking a moment to answer those. Just a reminder, you can either type your questions into the chat box, or please feel free to ask your questions as well. You'll just need to press *2 to unmute your phone line. I'll give everyone just another couple seconds on this set, and then we have one more set of questions I'll flip to in just a moment here. All right, that